Welcome everyone. We're right at the beginning of the meeting, so I just want to introduce myself, and then we'll start with introductions. So this is session 6 of the ASU ECHO hub on integrated care management. So we are focused on best practices for designing and improving the operational financial side of behavioral health integration in primary care. So my name is Matt Martin. I work here at ASU, and I'm the director of this ECHO group. So we're going to start with introductions. Let's start with those who are on video, and we'll start with those who are not part of the ASU team. So let's start with Sarah Pedraza. If you go ahead and just state your name and also your institution, organization.
Matt, she just put a note in the chat that her mic's not working.
Okay, sorry. Okay, I should have seen that. Thank you, Adrian.
Yeah.
So welcome, Sarah. We're glad to have you. Let's next go to, I see, is that Jeff?
Yes, it is. Can you hear me?
Yes.
Hi, I'm Jeff Leichter. I'm the lead administrator for behavioral health integration for Sanford Health, which is located in the Dakotas and Minnesota.
Great. Welcome, Jeff. Glad to have you here.
Thanks.
Let's go next to Maria Colon.
Hi, I'm Maria Colon. I'm a ASU DVH student, next to graduate in December. I work at a rural healthcare clinic in Archer, Florida, North Central Florida.
Wonderful. Welcome, Maria. Thank you. Let's go next to Jen Monkman.
Hi, I'm Jean Monkman, and I'm from the Institute for Clinical Systems Improvement, or ICSI. We're located in Minnesota and part of the Minnesota Health Collaborative, and we're focused on IBH integration into primary care.
Wonderful. Welcome, Jean. Thank you. Let's next go to Kara Hill. Just go ahead and introduce yourself. I'm assuming your microphone works. Okay, Kara, we'll come back to you. If you need to unmute yourself, there's an icon. Oh, it looks like you're unmuted now. Go ahead, Kara. Oh, maybe not. If you need to unmute yourself, there is a small little microphone icon in the left-hand corner of your window. You just have to click on that. If you're having any trouble with your microphone, you can also select the audio feed using that same icon area. Okay, continuing introductions, let's next go to Brianna. Brianna, are you there? Can you hear us? Looks like you're on the phone. You might be muted.
I'm
there. We can hear you.
Oh yeah, you can hear me now?
Yeah, go ahead.
Oh great. So my name is Brianna Reeser. I am with Care First Managed Care Health Insurance Plan, and I am their Integrated Health Initiatives Manager. I work with all our integrated health homes and their contracts specifically for partnering with value-based arrangements with our integrated partners to help them supplement their payments.
Okay, wonderful. Welcome, Brianna. Glad to have you here.
Thank you.
Let's continue with people on the phone. Let's go to the next phone number is 310-428-4161.
Hello, my name is Clarissa Aguilar. I'm a behavioral health consultant for the Center for Healthcare Services in San Antonio, Texas, where we do integrated care in a bidirectional setting, and we are growing our integrated practices and scaling across the center. We're moving toward a CCBHC model, which is looking towards prospective payment plans. Thank you.
Wonderful. Thank you, Clarissa. We're glad to have you here. Okay, let's see. Another phone number I see is 603-491-5655. 5659. Go ahead and introduce yourself.
But I'm a psychologist in Maine now, and worked in family medicine education, and now working with the DISREP program.
Wonderful. That sounds like Bill Gunn. Welcome, Bill.
Yes. Yep.
Great. Glad to have you here. Okay. And then let's go to the ASU team. Let's start with Cathy, who's doing our didactics presentation. Cathy, go ahead.
Hi, I'm Cathy Hudgins, and I am previously the Executive Director for the Center of Excellence for Integrated Care, and then most recently worked with Arizona State to help develop their Master's in Integrated Healthcare Management program, and I'm also an independent consultant.
Wonderful. Thanks, Cathy. Let's go to Adrian White.
Hello, everybody. My name is Adrian White, and I'm the director of the ASU ECHO programs.
Great. Let's go to Tyler Dunnington.
Hi, my name is Tyler Dunnington. I'm a former graduate student at ASU in the College of Health Solutions. Still helping with Project ECHO here, so glad to be here.
Great. Thanks, Tyler. And then let's go to Mahalit Walker.
Hi, my name is Mahalit. I'm an intern for Project ECHO and an undergrad at ASU College of Health Solutions as well.
Great. Thanks, Mahalit. Okay, I think I got everyone. And I just saw the message from Kara that her mic is not working either. So if anyone has any microphones that you're not using them anymore, send them to Sarah and Kara so they can we can hear their wonderful voices. Okay, so before we jump into the didactics, one thing that I like to do is just let people know about resources as part of our orientation. But before I jump into that, just to remind you about the purpose of ECHO. ECHO is all about creating a network of learning. And we connect with sites across the country who are interested in learning more about behavioral health integration. And so the goal is hopefully we can provide some information to you, but we also want to learn from you and hope that you'll learn from each other. For those of you who are clinicians, ECHO is a lot like peer supervision, if you ever had that experience during graduate school. So the point here is to learn and to try to advance the field together as much as possible. So we're looking forward to hearing from you and learning from you. If you want to present a case in the future, if there's some kind of issue or excuse me, challenge at your particular site that you want some feedback on, please reach out to me or to one of our team members, and we would be happy to have you do a case presentation and get some feedback. So I'm going to share my screen now. That's one of the nice things with Zoom. For those of you on the phone, you won't be able to see this, so I'll try to describe it as much as possible. So the resource I want to let you know about is the National Center for Integrated Behavioral Health. This is a site, a center that is funded by HRSA, and they've been around for, I think, about at least 2 years. They're located at the University of Pennsylvania, and they have a lot of great resources for those who are interested in integrated behavioral health. They also have a newsletter and a webinar series, so I'd encourage you to sign up for the newsletter. I think it comes out once every 2 weeks or so, and it seemed to be a nice place for additional information. Also, as a side note, Cathy Hudgins is on the board for the National Center. Okay, so let me stop sharing my screen. Okay, so we're going to move to the didactics part. This is where we have someone in our community who presents on a topic that they have some expertise in, and we're going to be spending about 10 to 15 minutes learning from Cathy. And then we'll have some time to do some questions and answers as well after that. And then after that, we'll move to Maria, who's going to do the second part of her case presentation, and we'll talk more about that. So Cathy, I'll turn the time over to you, and if you've got your slides ready, you're welcome to share your screen.
Okay, can you all hear me?
Yes, we can.
Okay, and can you see my slides on the screen?
Perfect.
Okay, well, welcome. And I just have to preface this by saying this is a huge topic. And I know that I only have 10 to 15 minutes, and those of you who know me know that I am not a woman of very few words. So I'm going to do the best I can. Also, after this presentation, there will be a list of resources that will go out to the group that will include references for you to read, but also resources and places to access this information. I will not go over the learning objectives in total, but just to let you know, we're going to look at site assessment tools. We're going to look at the rationales and uses for these. We're going to talk about the procedures for executing an effective site assessment and then determining the right integrated care site assessment for your organization. And I will be giving several examples. I want to just also say that I have I started doing technical assistance and program building, oh gosh, 6 or 7, maybe 8 years ago. And when I first started, these tools were really at the beginning of their inception and their use. My team at the Center of Excellence for Integrated Care in North Carolina, we pretty much, because of our funders and the groups that we were working with, we had to identify tools that fit a large number or a large group of projects, and sometimes they didn't always fit, but I'm going to be drawing on that information and that experience. I still, as I'm working with programs in large organizations today, use site assessment tools pretty much systematically throughout all of my program building and strategic planning. So I'm a big proponent, so you'll hear me cheerleading a lot. So what is an integrated care site assessment tool? First of all, these measurement tools identify the key aspects of integrated care program development and improvement. So they typically target the core domains of integrated care or some aspect of a program model. I say that because the one that is developed for the collaborative care model does not cover all of the core integrated care domains that are provided in the lexicon, which is another resource that you may, if you do not know what that is, please download that from the Agency of Healthcare Research and Quality, and I think it's also included on the Collaborative Family Healthcare Association website. Most of these, and when I start with the examples, I'll let you know which ones do or do not really identify the core domains or draw from them. Many of them, and I didn't have this on here, also either draw on the continuum, the 5 or 6 level continuum of integration, or the 3 basic buckets of integration, which would be coordinated, co-located, and fully integrated. So somehow they parse these out, and I will be letting you know which ones sort of fit that if that's something you're interested in. These are often developed by groups of experts in the field or integrated care organizations, and many times they're funded by large organizations or entities like CMS, or they'll be driven by philanthropic work, maybe Robert Wood Johnson. And so if you look for the funder, sometimes selecting the right assessment tool that may or may not have any conflict of interest for you, you may want to look at that as well. So looking at the origin is somewhat important. They're accepted by major federal, state, and philanthropic funders for reporting purposes, many of them. Even though they are not validated, there are some that have done some validation studies, such as the PIP, which we'll talk about, but none of them have been validated as like a psychometric tool. They're working on those, but it's coming. It's just one of those things where this is such a new field. These are evolving. They are almost all self-report. There are a couple, if you look on the SAMHSA website, that for the dual diagnosis treatment model, the IDDT model, and those are partly self-report, but they are also executed by an expert who typically works from outside of the organization. They're not evaluative unless used specifically for reporting. So when you administer these or work with these types of assessment tools, it's not to say you're good or bad or you're not doing what you're supposed to do, although sometimes they can work that way, and we can talk about that when we talk about execution. We do not use those to evaluate a site for anything other than readiness. And then some of the core domains where they can measure something that they may have to report on for a federal, state, local philanthropic grant. Some provide implementation guidance, and some are just merely giving you a score. It depends on what you want to use it for, and I'll talk about that in a moment. So this is another consideration. Many of them will provide examples, but they do not offer you any type of guidance. In other words, this is not an implementation tool in many ways. People use them as implementation tools. I know Bill Gunn is on the line, and we've used the MEHAF as a way to implement and target strategic planning. And but in their nature, these assessment tools do not provide guidance. And they parallel patient care. And I wanted to put this in, didn't know how to even address it. But what my team and I learned very early on is that because we're all clinicians, and my team, we were all clinicians, we approached helping our programs and our sites and our organizations like we helped our patients. We needed an assessment in order to identify the goals and the things that we wanted to work on, and then to be able to measure progress, just like we do with our patients. And so if we think about a PHQ-9, you're going to revisit that to see how they've progressed based on what you've been doing with them, and to set those targeted goals. So I really do see the assessment as a parallel. Also, just by taking the assessment can be an intervention. Just like sometimes doing a screening or an assessment with a patient can start that intervention process, because you're raising the opportunities and the hope and the awareness just by having those conversations. And also, if you're doing a consensus score where a group of people are doing the assessment, it also raises questions like you would in family therapy about different perceptions. So us in the systems thinkers, we're looking at this just like that type of systems exercise. So why would you do it? Why would you even embark on this type of assessment? And I get this question a lot, because one of the things I try to encourage the sites I work with to do, and it does take some time, is to complete the site assessment before we start a training plan. So first of all, it evaluates the program status. You want to sort of know where they are on some of the core domains. If it's for a federal grant, and I know HRSA has definitely espoused the continuum, the 6th level, and they have written that into their grants, the federal grants. And so if you need to report or determine where you are on the levels of integration when you apply for a grant, some of these tools are perfect for that, because it uses the same language that HRSA is using in their federal RFPs. It helps you track progress, so you can identify core areas and domains of improvement and development, and then reassess to see if you've been able to move down that continuum using the same systematic processes and measures. Otherwise, when we first started doing technical assistance, we would just say, hey, what do y'all want to do? Where do you want to start? And they always wanted to start with money. I'm just telling you. What can we bill for? Always. And so backwards. And then you would have to ask, okay, let's back up. What population are you going to help? And what are you going to do? And what are your goals? And who's going to do what? And how many people do you need? So it really does help people keep from starting in that place where, they're really focused on. Assists with strategic planning, so you can identify the goals that everyone wants to work on. If they are logical to start in those places, again, just using that last example. And then it helps with the strategic planning process, because typically these types of assessments have some increment of movement up or across. So you'll be able to see the change. It helps you gain an accurate view of the program against the national standards. So some of these, you would put your information in and you would get out in the output some type of comparison to other like sites in the United States. But also, if you're using the core domains of integrated care, when you're reading the literature and someone is reporting on something that they're doing, so say for instance, universal screenings, you can actually compare what you're doing to what other people are doing in the national standards. So you have a common language as well. Determine areas of improvement, QI, or development. We've talked about that. Determine resources needed for staffing and workforce development. So at this point, you may identify things that you don't have. You don't have the right staff to actually execute these components of integrated care, or you don't have the training needs. And this is another thing that helps you identify credentialing and training needs. So if you're looking for training topics, you go back to your assessment and say, where are the gaps here in what we are doing, and where do we need that additional training and assistance? And then for reporting, marketing, and fundraising, this is becoming a common language. And if you are able to generate reporting measures that other people are looking for, even if it's some of your outcome measures that may be remotely related to integrated care, like readmissions or things like that. Some states are very focused on those. Then you can actually use this as part of that reporting, marketing, or fundraising, writing grants. So I wanted to pick a couple. So if you look on the SAMHSA website, the Center for Integrated Health Solutions, there are more than this, and then actually they don't include some of these. The Agency for Healthcare Research and Quality includes most of these, and some background information. All of these are accessible on the internet. I did not choose any that you had to write for, that you had to pay for. They're all accessible. Some ask that you log in and create some type of account, but most all, if not all of them, you will be able to download in paper form. So I'm not going to go through all of the information, but I wanted to give you sort of a brief snapshot of who developed these, how they were developed, why they were developed. I won't be able and do not have time to go over all the nuances, but I want to go over a few things about these. So the IPAT was developed by the Center for Integrated Health Solutions, by this group of authors. And actually, it's a decision tree format where you have you follow these 8 questions, and then when you enter your information into their system, it will give you the output of your score, where you are on the 6 levels. So, for instance, if you've answered all the questions, and just FYI, if you cannot say yes, that you do whatever the question is all the time, you have to say no. So this one seems to be a little bit downrated a little bit, so you may get a lower score than you think you are, but it is against the fully integrated system, so everything is counted against the level 6. And so this one, say for instance, you're not doing everything, it's not operationalized, but you're doing some things, it's somewhat co-located, you may get a 3.5 out of 6. The Behavioral Health Integration Checklist from the AIMS Center, that's the Washington Advancing Integrated Mental Health Solutions Center. This one is, if you are using the collaborative care model, you would want to use this one. The IPAT, you may or may not be able to assess the level of integration of your collaborative care model. It is better for more things like the primary care behavioral health model, or some program variations, such as a hybrid version of both of those. The IPAT is not very good for the bidirectional models. If you're doing a vertical protocol like an SBIRT, screening, brief intervention, referral to treatment, the IPAT's somewhat okay, but still it may, it's going to ask you questions that are not related to that specific protocol model that you're using. So being very, understanding what model you're using, these are that's specific to that. So if you're using the collaborative care model, the AIMS is fairly good. It's a short checklist. It's paper download. So you would do it on paper, 9 characteristics. It's on a 1 to 10 Likert scale. It's fairly short and easy to do, but it doesn't have very many directives. It's based on principles of care and core components and tasks. So it doesn't give you any implementation direction. They do offer a checklist and some resources online after you download it, and then you complete it. The BICA, so the BICA, we talked about state and federal and philanthropic drivers. The BICA was selected by Arizona to, I guess, measure their integration, which their initiative was bidirectional, and I know Dr. Manson was very integral into that project. It is meant for bidirectional sites. If you're doing a traditional medical or primary care integration project, it's really not going to help you very much. It measures you on 3 levels. This is the one that's coordinated, co-located, or integrated. It's not along the continuum, and it does not use the entire lexicon and all the core components for that. It has 5 sections that include things like population, infrastructure, finance, and it does offer some examples. So it gives you a little bit of guidance, but not very much. You would have to then go deeper into the resources for that one. The MEHAF, the Maine Health Access Foundation Site Self-Assessment, this one, I've used this one for major federal grants such as Practice Transformation Network grants, DISRIP grants. Bill and his group, we actually helped them, the Center of Excellence helped them sort of work with the MEHAF and use that to gauge their program development and reporting and training. Did the same thing with the Practice Transformation Network grant in North Carolina, the DISRIP in New York. So this one has been accepted also by HRSA for reporting on the HRSA Integrated Care Expansion Grants. This one, we use this one at Wake Forest for that. So this one is actually in 2 domains. It uses the core concepts of the lexicon. It's on a 1 to 10 Likert scale. It has clinical and operational domains, 18 questions. It is paper download only. The Center of Excellence for Integrated Care, because we also in our DISRIP in New York had collaborative care and bidirectional, we adjusted the MEHAF, added 3 questions that would expand it to measure collaborative care. And then we also, even though, and it does measure bidirectional integration, but you have to change the language a little bit if you're working with providers. So we created a bidirectional version, but it also, you don't really have to do that the way it is. And Bill Gunn may be later be able to answer if they did that. I know that we did. I don't know if we shared the bidirectional version with you all. So it's adjustable. You can download it. It's fully editable. You can edit it to make sense to your language if you use the word consumer as opposed to patient. Many of these come out as a PDF and they cannot be changed. But that one in particular, you can edit. And then let's see, the PIP. The PIP I'm not as familiar with, and that's somewhat shameful because Kessler and Maki were the developers. But this one is online. This one actually aggregates national information to show people where they are against their peers and like organizations on the core domains. It is based on the core domains of the lexicon. It does not provide guidance, but again, just like any assessment, it does, the intervention sometimes poses some of those, what could happen. things, and I will talk about administration in a minute, but these that are only online, you can download the questionnaire from there, but if you will not get to enter and then receive your score if you only do it on paper. And it is a 30-item web-based. So it's 30 items. Most of these are between 8 and I think 30 is the most questions that you'll see on one of these assessments. So which one for your type? I know now you're like, well, hey, I logged on here and you were going to tell me. So what is it? Give me the answer. All right. Well, it's, again, I cannot do that for you unless I talk to you directly, but I can give you some tips on how to choose the right one for you. First of all, look at the model or program type. If you're doing bidirectional, obviously, if your organization is a mental health organization and you want to put, or behavioral health or substance use organization, and you want to add in primary care, you're doing bidirectional, you probably would want to use the BICA, or you could use the MEHAP, depending on what you want to know. Organizational type, again, sometimes, your organization will choose what they want to know. They don't really care about all this continuum things, but they want to know about these specific domains. So your organization type sometimes will drive that, as will the rationale and the drivers for that. So for instance, if it's for strategic planning and you have to have a full, quality improvement initiative report, you're just, planning the whole thing, you may want to break it down on one of these that has all the core domains broken into the separate sections, so you can show where you want to go in each quarter or each PDSA cycle, which, the MEHAP again does very well. The IPAT does a little bit of that, but it's more on that visual. Let's see. And so it's up to you. If you're doing collaborative care, obviously you would want to use that one. If you're, the purpose and the use of the information, this is where I would look at all of them. If you really need some guidance, you may want to use ones that have more examples, so where they're broken into more discrete parts or levels. If you are just wanting to see where you are, or you're going to write a federal grant and they ask your level of integration and all you want is that number, then you may want to do the IPAT online, or you may want to do the PIP and use some of the information in the output. Your current status of your program. Some folks want to do these assessments before they don't even know what they're going to do. Now, that can be really educational because you actually level everybody's knowledge. But it can be demoralizing when you get a 0 on everything, right? On every domain. Even though some of these things they may already be doing, such as, using patient surveys to drive program development. But if it's not focused on integrated care, you're going to get a 0. So looking at the current status of the program, where are you? If you're really down the line, I have a site right now. They've done a lot of things, but they're really lacking on, they have a lot of no-shows, and they want to increase patient engagement. They have so far not wanted to do an assessment. I walked in and they were actually working pretty well, but now it's time to go back and see what they're doing that would help engage their patients more and their families. Level of knowledge. So some of these require somewhat a deeper level of knowledge to complete the assessment. So you need to make sure that someone at least has the understanding or is able to gain that understanding. Some of these, like the IPAT, which are more general, are easier to do than, say, the MEHAP, because you really do need to somewhat understand the core concepts of integration. Objectivity versus subjectivity. Some of these are obviously they're self-reports, which is a limitation, right? If you feel like your group is not very objective, we're going to talk about gaining a consensus score. This one in particular is going to be really important. Do you feel like you need something that you just enter into the system and that spits out your report, or do you want to take the time to have those group discussions? Group buy-in and willingness to participate. Some of these only require 1 or 2 people to complete. Some of them recommend key personnel from each area of the program to complete. So buy-in and willingness to participate is important. And then preference for methods of administration. Some sites I've worked with are really not, I mean, they're in the deepest parts of, rural America, and they don't have access to the internet consistently, and it would be very difficult for them to do this. I'm going to speed up. I know everybody's like, oh my gosh, we're moving too slow. So how do you do these? Here are a couple things. Self-report, but maybe facilitated by an outside expert. You can do this yourself. You need to have somebody, a champion maybe, or someone who understands. I recommend that it not be facilitated by someone who is a decision maker or someone who hires and fires. Because if someone says, we don't really screen everyone, even though that's your meaningful use indicator for your PCMH, then you may get fired. So don't do that. You need someone who has good facilitation skills who may be more separated from the decision making, but the decision maker should be included. Most are meant to be taken in multiple times to show progression, ideally taken by different members of the site staff, but some of these do not require that. Some of them are just log on, take it, it's your perspective, you get the number, and then there you go. I don't agree with that administration necessarily if you can do it the other way, because otherwise you're going to get one person's perspective and it's typically not comprehensive. You can take it individually and then the group develops a consensus score. So I recommend that people do it separately, then get back together with their implementation team, key members, and then they decide what is the score. If you have a 2 and I have a 5, why are we different here? What is my perspective different than yours? And that's where the facilitation really comes in. Online versus paper versions, we've talked about that. It depends on how you do it, but you can do these either way. If it is meant to be online, it'll be frustrating if you do it via paper because then you have to score yourself or you may not get the same output. Led by someone in the organization with a basic understanding, we've already talked about that, and then used as a central part of the development process. I've worked with a couple organizations that had 250 sites do these and then nothing. It's like doing a PhD, like screening everybody for depression, and then it goes into the EHR and you move on. Like, then what? So what? We don't follow up, we're not using it. So again, that's frustrating for the person taking and administering the exam, this assessment, and the people who have spent their time. It's just one of those things that you have to do, and then it didn't do anything. So if you're going to do one, make it work. Couple last tips. Research them to see what fits. Use literature to identify any core concepts in any of those that you really feel fit you. And figure out what they mean before you answer the questions. We've been all over the map with that when some folks do not have the basic knowledge and then they just jump in. They don't know what a registry is. They think a registry is that notebook underneath the front desk that somebody writes somebody's name in because they keep no-showing. No, that is not a registry. It's a great start, right? But that's not a registry. If people are, completing the assessment, ask if they do not complete it with anybody else in the room. This kind of influence of each other's answers, it's because we're a system. We really think that everyone should answer it individually after they somewhat understand. And if they don't understand a concept, only go to the facilitator for the question. Don't ask everybody else, what did you mean by a registry? And then all of a sudden the discussion ensues and now we have influence of your perspective. And then encourage your group to use the information again as part of the ongoing process. Woo! How did I do? Oh, I went over, sorry. So.
That was great, Cathy. Thank you so much. We do have time for 1 or 2 questions. This is a great presentation on some really helpful instruments you can use out there for assessment. If anyone has any questions, you can go ahead and unmute yourself or send it through chat.
I have a question. This is Brianne, if you can hear me.
Yes, go ahead, Brianne.
I'm going to jump in and do the selfish thing and ask specifically for me what would be the best tool to use. So I'm coming from the payer's perspective, and I have the task of auditing all of the integrated health homes that I am contracted with to be able to get a better idea of where we are as a network, and then more importantly, my job becomes how do I support integrated health homes with finances and resources to improve and flourish? So what would be a good tool to use for that specifically?
So what is the goal for that? So I know you're saying, oops, didn't want me to do that. So when you're talking about looking at the finances and resources, which it's really, these are meant for, are you looking on staffing levels, or are you looking at training resources? So gaps in knowledge base?
I'm looking for, so I'll have level 1 or 2 and then level 6s. I have like a mix of providers in the network, and I'm looking to be able to find where they're at that point in time and what resources are best for them. So how can I, as a payer, help them move into a higher dollar amount or get them on a value-based arrangement or alternative payment method that supports integration?
So it sounds like you were saying that some are a level 2 and some are 6, but I'm not sure how you know what those levels are. So they could begin by I don't know. So do you all use some type of measurement in order to identify those?
Like you said, it's a self-reported, probably IPAT. Lots of them are TIP program spots, but I'm not sure I trust, like you said, the self-reported aspect of that. So I was wondering if there's something more suited for the payer perspective.
Right.
View.
I think the MEHAP is probably the best one we've used because we've used it in large groups of organizations, and then you can compare people for what they need. So for instance, if you're measuring things like basic shared decision making, so shared treatment planning. And you know that if you're looking for a training resource, you know that they're not doing that. Sometimes they do, but they don't really, they need more resources to expand their EHR capacity, or maybe it's data mining. They don't know how to do that, or their EHR, there's capacities, but you're going to have to expand the funding for your vendor to actually help them understand what they're looking for and how to get that information. That one breaks it down. I think the PIP also probably does those. I mean, it's got 30 questions and it's got a lot of all of the core domains. If you're not looking at really basic guidance for how to get down the continuum, you just want to see where they are on each of the domains, that one's probably really good. And then you can compare it to the national averages. So I hope that was helpful, because I think the iPad's great. It's great for people who are starting. But then what?
Right. Okay, thank you.
Great question. Cathy, if you will, send your slides to me, and if you're okay, we can put them on the ECHO website, if that's all right with you.
I'm fine with it. I will add the resource page to it, and thank you so much for giving me your attention.
Wonderful. Okay, so yeah, those slides will be available on the ECHO website, and Adrian or Tyler, if you'll send out the link through the chat, just so people have that site. So we're going to move on to our case presentation. So this is part 2. This is the sequel for Maria. Let's see, she may have, oh, there she is, okay. I saw one person drop off. But yeah, Maria's still with us. So this was about a month ago that we started talking about Maria's site, and then we ran out of time. Just to remind everyone, Maria is looking to increase screening and referral rates for behavioral health services, and also overall just to increase access to the behavioral health provider. They've done a lot of work in the past at her site to train the medical providers, to create protocol and effective workflow to bring the patient to the behavioral health provider. There have been some issues. It sounds like in the past, the behavioral health provider who works at another site will sometimes not be on site and be available. So there have been some scheduling issues as well. So I'm going to turn the time over to Maria, and she'll just catch us up on her site. And I think the place we left off last time is we were just about to give recommendations to Maria. So Maria, if you'll just fill in any gaps that I left out, and then we can have a discussion about what you're specifically asking for.
Sounds great. I'm gonna pull this up because that way everybody can see. Let me see what screen this is supposed to be on. I think it's screen 1. Okay. Am I sharing yet? Doesn't look. I am? Okay. I can't see what I'm sharing. Okay, I'm sharing on this. I have three screens up, so that's why I didn't know. So basically that's where we left off. You were currently right. Our project basically is what you said. We were looking to improve the screening, identification, and referrals to behavioral health from a 4.6% to a 10%, and increasing same-day access. Actually, when we're looking at increasing, that word should have actually been adding, because at the site there was no access to same-day behavioral health provider. Basically what we were gonna do at that point when we weren't able, our time was cut off and we have about 13 minutes left right now, so I wanna go quite fast, was that the cohort was gonna ask me any questions. I had very good questions asking in reference to the training to the behavioral health provider and the site. And I did explain that I had provided the training to the behavioral health provider basically on everything that I've learned in ASU's DBH program. She was my supervisor, so the expectation was that she knew behavioral health integration better than what I would. But what I've learned in this area in North Central Florida is that like in many places, there's not a lot of providers that understand what brief interventions is. There's not a lot of providers that know how to make a transition from 60-minute sessions to 30-minute sessions. So it's gonna take a long time. As we were doing this project, it was my CP2 project, CP3 project, and the thing was the length of time was only 4 months that I had to do this project, even though we've had progress from 58 patients that they were referring to behavioral health in 2 months. It increased to 105 patients. Now looking at the data, I can smile. 105 patients that were referred to behavioral health, which was not a big increase, but it is still an increase to what they were doing before. So I don't know if you have any questions. My questions for the group at the time when I presented this was, besides training the BHC provider, what other strategies has the team used to improve behavioral health timing with patients? We were having a timing issue. She was seeing patients for 72 minutes, and we were expecting her, and her schedule was set to 30-minute interventions. And my other question was, how has the team encouraged primary care providers to use same-day access instead of system referrals? And that issue came about because within the program, or how the agency decided to do the program, they decided that they were going to have the same access, same-day access referrals, but they were also going to allow the providers to refer to the system, which is okay if the provider is not there. But what started happening that even with the provider on site, they were preferring to refer to the system, basically saying we completed this task, but they weren't using the provider on site. So those were my 2 questions, and I'm open for recommendations. Even though I'm not at the site anymore, they're still waiting for my recommendations and my final project. So I would love to include that in my CP3 paper.
Great. Let's start with clarifying questions. Maria, this is an excellent case and probably a common issue in terms of using a brief therapy model and also increasing same-day access. So let's start with anyone who has clarifying questions. If you have any questions for Maria, go ahead and send them through chat or just unmute your microphone, and we'll start there. While people are thinking, I can ask a question. Maria, will you tell us what is the current workflow for the same-day referral when a provider wants to connect a patient with the behavioral health provider, what's the current procedure to make that happen?
So basically, when we looked at the workflow on the current state with the agency, we observed some patients. The patient would check in at the front desk. It would take about 3 minutes. Then the patient would check in 2 minutes. Would check in. First, the sign in is they would come in, sign in a sheet, sit there. Then the front desk would call them, sign in, check them in the system, and let the provider know that they're there. While that happens, then the patient goes and sits in the lobby, and they're seeing they have this little TV where they see TED Talks, educational videos. That usually would last about 12 minutes, the patient waiting for the MA to come and pick them up. And then at that point, if they're seeing the primary care provider, they would see the primary care provider. And if the primary care provider determined that there was a need for behavioral health, I didn't say before the primary care provider goes in and the MA sees the patient, they're completing the PHQ-9 and they're completing the alcohol screening. Once they do the audit. Once they do the audit, they are supposed to talk to the primary care provider and let them know this is what's happening with the patient. The patient has these scales high, and let's go ahead and give them an alert. Then from there, the primary care provider would talk to the behavioral health consultant, do a warm handoff. Behavioral health consultant would come in and see the patient. However, when the patient was coming directly to see the behavioral health provider, they were coming in, checking in. Basically, that front process was equally the same, but instead of an MA looking for the patient, it was our behavioral health provider getting the patient, staying with them for a very long time. And then she would check out the patient herself in the system, which we talked about that. That's something that she shouldn't do because sometimes patient had to pay. And additional to that, she would give them their next appointment. So if the behavioral health provider with primary care referring to behavioral health, it was about a 47-minute process. With the patient seeing solely the behavioral health, it was about an 89-minute cycle time.
Okay, yeah, that's very helpful. So Maria's looking for any ideas on how to make sure that the behavioral health provider is following the 30-minute appointment schedule, or any ideas for how to increase that same-day referral access. So if anyone has any thoughts or recommendations, anything that's worked at your particular site, go ahead and chime in through chat or through your microphone.
Hey, Matt, this is Leslie. This is Leslie Manson. I was just going to chime in, but I wanted others to have a chance of chatting or giving suggestions before I did.
Sure, go ahead.
Or do you want me to go ahead and jump in?
Sure, yeah.
Okay, so I think there's another way. There's a number of ways to look at reduction of time. I know we only have 5 minutes right now. Oh my goodness, that's a reduction of time. When we look at this, there's a few different things to really consider. Is I usually try to meet with the clinicians and talk to them about what are their strengths related to their interventions, and get a better sense of what they're doing in the room and see whether or not they feel that they're having difficulties with managing their own time. Then I train them a little bit on the actual 30-minute model, and what that looks like is, what are you supposed to be doing within the first 1 to 2 minutes? What are you doing within 3 to 5 minutes? What are you doing within 7 to 10, 11 to 12, 15 to 30? So that's all modeled out and timed out, which is great. So I train them on that as a second step as well, so that they can really understand that. And then we kind of do modeling and practice. And I have them view appointments with me or with someone else who's doing it well, because oftentimes folks are just so much into what they do, it's very hard for them to visualize what does that look like different. And there's a lot of apprehension that you can make real clinical change with it being such a shorter model, right? Because they're just not used to it. So a lot of that shadowing, I think, is really necessary and very, very helpful. And so that's something that I have done before. And then I also will encourage them to actually help structure the time with the patients. So that structuring with the patients can be done at the front desk. It can be done when they take the patient back. And we help work on very specific verbiage like, hey, thanks for coming in today. I want to sit down. And then there's some verbiages that have been demonstrated before and thrown out there that people can, cut and paste and use. And it's basically just setting the stage for the patient that today we have this amount of time together. I'm going to end at this time and we're going to go over X, Y, and Z. What did you want to go over? So it's kind of setting the stage. And you do that at the very beginning of the appointment. And so both of you are responsible related to the appointment time. And that also gives that ability to be able to check in on the appointment time. I make it very transparent about time. And so that people can feel like, okay, this is something we can talk about. It's not something that, ooh, we don't want to talk about time when the patient's in the room with me. So I really help them to walk through that as well. And we write out a script regarding it. And like I said, there's published scripts out there as well to use. So those are just a few of them. I know there's not much time, so I'm giving you 2 minutes. Okay, next.
That's great, Leslie. And I think that's the right way to go, because it sounds like the schedule template has already been set. These are how the appointments are being created in 30-minute slots. And so the real opportunity to change is to work one-on-one with this behavioral health consultant. And it does sound like it may be a lack of just training and knowledge about how to use a brief therapy model. Are there any?
Matt, I have a quick suggestion. Also, educating the medical providers. They may not understand the potential of what's supposed to happen. And also, typically they drive, since they lead the team, they drive the pace. The nursing staff can also put in their, oh, we have another patient here, we're waiting. So some of that pressure actually moves the bottleneck along. And then the huddles in the morning, if you can identify by scrubbing your, the schedule for a number of patients who may be really good candidates for that same day, and then having them check in and then check it off. Did you do this when you did that? So let's report on what that the report is on that huddle, and the schedule.
Mm-hmm. And exactly what Cathy was saying is also going to help with that other question that was posed related to how to get them more utilized. I think the huddles are really essential and data mining, but it's time.
Wonderful, wonderful comments. It seems to me that since Maria is not on site anymore, that any of this supervision or training will probably have to come from someone else, unless they hire Maria and give her the big bucks to do this training and supervision. So we'll see.
Well, yeah. Well, I appreciate your comments and everything that you've said. Most of the things, I'm very transparent, but most of the things that you've commented on or given, we created that. I sat with her. I took her through the process. I even provided her the videos that I did of brief interventions for my brief interventions class, which I got A's on. Provided her YouTube videos to see one of the doctors that were recommended to see a lot. I forgot his name, but so I did provide a lot of education. It was, I don't know, I felt like there was some resistance to the change through that process. Because, for example, if I'm observing you one day and you decide to go to a different clinic to see a different patient, when we can do it through telehealth, then that I think the limitation more is, I'm as a student, you're coming into a clinic and you're trying to provide all of this information in a short amount of time. And it's very hard for someone that is the director, because at that point they're the director and the one providing the care, to kind of sit down and do it in a different way. We also created a video, which is something that's not here, we didn't talk about today, but we even created a video of the workflow, and all the primary care providers were trained on that. And I know we're out of time, it's 4, so I'm not talking anymore.
Thank you, Maria. There have been some great comments about possibly using MAs and nurses as part of the integrated care service. There have also been some comments about how this particular clinician may not be a good fit for integrated care. And that may have to be a conversation that a manager or an administrator has with the individual. And that's not uncommon. That's not a bad thing. they may be a better fit for longer traditional mental health. Maria, great case. Thank you for all the comments and recommendations. This is the end of our meeting. The next time we meet is going to be Friday, June 14th. If you want to be part of our email group, just send me your email address and we'd be happy to add you. I hope everyone has a great weekend. Thank you. Bye-bye.